Welcome back to the Deep Dive. I'm your host, and I'm really excited to get into today's topic.
And I'm your resident expert. I am very ready to unpack this one with you.
Yeah, because today we are getting literal. We're talking
Yeah.
about the thing that actually holds you together.
Right, the central pillar.
Exactly. We usually go through life thinking of our spine as this simple stack of bones, like a, a roll of quarters.
Or a rigid tent pole just keeping us upright.
Right. But when I started looking through these anatomical texts and the ossification diagrams you sent over, I realized it's not a pole at all.
Not even close.
It's a machine. It's this complex, shifting engineering marvel that completely changes its architecture from top to bottom.
It has to. I mean, think about the conflicting demands we place on our backs every single day.
Yeah, it's a lot of pressure.
It really is.
Right?
We need the top part to protect our heart and lungs, so that has to be rigid. But then we need the bottom part to carry the weight of our entire upper body and let us twist and bend.
So it has to be massive and mobile down there.
Right. And then we need the absolute base to anchor everything securely into our legs.
It's asking a lot of one single column of bone.
It is. And that's exactly what we're going to decode today for you. We're taking a journey straight down that central pillar of the human body.
Starting right in the chest with the thoracic vertebrae.
Yes, dropping down into the heavy lifting lumbar region.
Yeah.
And then finally looking at how the whole assembly anchors into the sacrum and forms the basin of the bony pelvis.
And what I really love about this source material we're using is that it doesn't just label the parts.
No, it goes much deeper.
It explains the actual consequences of those parts. We're going to look at why a slip disc usually happens in one specific direction.
Which is fascinating mechanically.
Yeah, and why some people are prone to back pain just because of a tiny bridge of bone.
And even how the shape of your pelvis is basically a huge compromise between walking upright and while having babies.
The ultimate evolutionary trade-off right there.
So let's just start at the top. Well, the middle top, the thoracic vertebrae, T1 through T12.
Ah, yes. The rib carriers. Rib carriers is the perfect name because looking at the texts, that is their defining job description.
It is. If you look at a typical thoracic vertebra, say right in the middle of your back, like T2 to T8, the first thing you notice is the shape of the body itself.
The text describes it as heart-shaped.
Heart-shaped, right? Which is poetic, but I assure you it's not just for romance.
I figured it's roughly equal in dimension from side to side and front to back, right?
Exactly. But the heart shape is really just the platform. The real engineering happens on the sides of that bone.
Yeah.
Did you see those little markings called costal demifacets?
Yeah, the demifacets. I actually looked that up because it sounded strange. It essentially means half face.
Half face, yes.
But looking at the diagrams, they look more like little shallow sockets to me. Kind of like a small shelf.
A shelf is a great way to visualize it because the head of a rib doesn't just glue itself to the side of one bone. It actually bridges the gap between two bones.
Oh, I see.
Yeah, the head of the rib sits right in a socket formed by the superior demifacet of its own vertebra and the inferior demifacet of the one right above it.
So the rib is acting like a keystone. It's physically locking two separate vertebrae together.
Exactly. It creates an incredibly stable, interlocked cage. And get this, it's not just a single connection point.
There's more.
The rib wraps around toward the back, and there's a second connection point on the transverse process. That's the little wing sticking out the side of the vertebra.
So it's a double lock system.
It's basically a triple lock if you count both of the bodies and the transverse process. This is what makes the thoracic spine so incredibly stable. It protects your heart and your lungs.
Because you definitely don't want your rib cage flopping around while you jog.
Right.
That makes perfect sense for protection, but doesn't that make us really stiff? I mean, if I tried, I can't really bend backward very far in my upper back.
That is entirely by design. And it's not just the ribs stopping you from bending. Look at the spinous processes in those diagrams.
Those are the bony bumps you can feel if you run your hand down someone's spine, right?
Yes. In the thoracic region, they are very long and they point sharply downwards.
Yeah, the source text mentions that specifically for T5 to T9, they're almost completely vertical. They physically overlap each other.
Like shingles on a roof.
Okay, so if I try to bend backward into extension, those bony shingles are just going to crash into each other.
Precisely. The bone physically hits bone. It's a hard mechanical stop. Nature is basically saying, do not bend this part of the tube. There are highly important organs inside.
I love that. But nature also loves a gradient, right? The text mentions some atypical vertebrae up there.
It does. Because nothing happens abruptly in the human body.
Right.
T1, at the very top, it looks a lot like a neck bone, like a cervical vertebra.
Transitioning down.
Right. And then down at the bottom, T11 and T12 start looking a lot like lower back bones. They lose those facets on the transverse processes because the floating ribs don't attach there. They're the shapeshifters of the spine.
Right. Before we leave the thorax, though, we have to talk about the clinical note in the source material. It brings up something that terrifies pretty much everyone.
Ah, the dreaded disc prolapse.
Yes, the herniated disc. The text mentions that while your discs are very strong in young adults, degenerative changes set in after the second decade.
The second decade, yes.
That's our 20s. That seems incredibly unfair.
Gravity comes for us all eventually. But here's what's actually happening mechanically. The intervertebral disc has this tough outer tire called the annulus fibrosus.
Okay, the tire.
And inside that tire, there's a jelly-like center called the nucleus pulposus. As we age, that outer tire gets a bit brittle. If it cracks under pressure, the jelly squeezes out.
And the source was very, very specific about where that jelly squeezes out. It said posterolaterally.
Posterolaterally.
Yeah.
That direction is key. It generally can't go straight back easily because there's a very strong ligament blocking the way there.
The posterior longitudinal ligament.
Exactly. So it takes the path of least resistance, which is back and slightly to the side, posterolaterally.
Which just happens to be exactly where the delicate nerve roots are exiting the spine.
Bingo. It's a total collision course. That extruded jelly puts direct mechanical pressure on the nerve root. And let me tell you, that's not just a dull ache.
No, it's sharp.
That is the searing electric shock type of pain that travels down your body. It's a structural failure that causes a massive electrical problem.
Well, speaking of structural failures and heavy loads, let's move down to the laborers of the spine. The lumbar vertebrae.
The heavy lifters. As soon as you cross that line from T12 to L1, the architecture changes completely. We lose the ribs entirely.
And we lose that heart shape.
Yes. And we get a massive kidney-shaped body instead.
A kidney bean. It really does look robust.
Notice the width, too. It's much wider from side to side than it is from front to back.
It looks like it's built to bear weight.
It has to be. Think about the physics involved. Pressure equals force divided by area. To handle the downward force of your entire upper body, plus whatever heavy box you're lifting incorrectly, you need a larger surface area to distribute that load.
If these bones were small, they'd just crush.
Right, they'd crumble to support the entire posterior abdominal wall.
I noticed in the diagrams they also have these little extra bumps that the thoracic bones didn't have. The text highlighted the accessory process and the mammillary process.
I love those little anatomical details. They might seem completely insignificant, just little rough patches on the bone. But they tell a story about movement.
How so?
Well, the mammillary process, which sits on the superior articular process, is the primary anchor point for the multifidus muscle.
Multifidus. That sounds like a spell from Harry Potter.
It acts like one, too. The multifidus is this incredibly deep, powerful muscle series that stabilizes your spine. Those little bony bumps only exist because those muscles have been tugging on them for millions of years of human evolution, reinforcing the attachment point.
That is so cool. But the real celebrity of the lumbar region, or maybe the villain, depending on your medical history, is L5, the fifth lumbar vertebra.
Yes, L5 is structurally unique because it is the ultimate transition point. It's the very bottom of the stack.
The last stop before the pelvis.
Exactly. It has the incredibly difficult job of connecting the mobile, flexible upper spine to the rigid, stationary pelvis.
Talk about a high-stress job.
It's the ultimate middle management position. To handle all that stress, L5 is the largest vertebra. Its transverse processes are thick, bulky, and pyramidal.
They don't look like thin wings anymore.
No, they attach directly to the whole thickness of the pedicle because they need to be strong enough to firmly anchor the iliolumbar ligaments.
And the spacing is weird down there too, right? The inferior articular processes, the bottom legs, so to speak, are widely separated.
Much wider than the ones on L4 above it. It's physically widening its stance to properly mate with the sacrum below. But this exact junction is where things get really risky.
Yeah, the text brings up some specific clinical aha moments regarding L5. Sacralization was one of them.
Sacralization, that's a congenital anomaly. In some people, L5 literally fuses to the sacrum during development. It just becomes part of the pelvis.
So instead of 5 distinct lumbar bones, you functionally only have 4.
Yes, it's essentially a hemivertebra situation.
Wait, so could one side be fused and the other side still tries to act like a normal joint?
Sometimes, yes. And imagine the mechanics of that. It's completely asymmetrical. It puts massive torque on the disc right above it because the normal shock absorber at L5 just isn't working.
But the more common issue seems to be the slipping. The text called it spondylosis and spondylolisthesis.
Yes. These are crucial concepts if you want to understand back pain. Spondylolisthesis is when L5 actually slips forward, sliding right down the slope of the sacrum.
But why does it slip in the first place?
The source points to a very specific anatomical bridge of bone called the pars interarticularis.
The pars interarticularis. Okay, let's break that down.
It's simply the little bridge of bone connecting the top joint to the bottom joint on the back of the vertebra.
So if I can use an analogy here, is it kind of like a trailer hitch?
That is a perfect analogy. Think of your spine as the car, and L5 is the trailer hitch connecting you to the heavy trailer of the pelvis. The pars interarticularis is the metal hook itself,
And if that hook snaps,
which is called spondylolysis. If it snaps, the car keeps moving, but the secure connection is broken. Gravity takes over, and the bone physically slides forward over S1.
and that slip is what crushes the nerves.
Exactly. And that leads to sciatica. The text clearly notes that a prolapsed disc or a forward slip right here compresses the roots of the sciatic nerve.
And since that nerve runs from your lower back all the way down the back of your leg to your toes, your brain interprets the pain as being in your leg.
Right. You feel the searing pain in your calf or your foot.
Yeah.
But the actual structural problem is a tiny fracture in your back.
All because of a broken bridge of bone the size of a postage stamp.
Terrifying but true.
Let's move past the slip and talk about what L5 is supposed to be sitting securely on. The sacrum and the coccyx, the absolute anchor of the central pillar.
The sacrum is fascinating because it is literally a history lesson in fusion. When you look at it, it looks like one large, flattened, triangular shield. But it's actually 5 individual vertebrae that fused together as we grew.
And it's not sitting straight up and down like a normal pillar, right?
Now, and this is critical for understanding our posture. It is tilted. The flat top surface actually slopes forward at about a 30-degree angle.
Oh, so that's why L5 is always trying to slide off it. It's literally sitting on a downward ramp.
Exactly. Gravity is always pulling it forward.
One visual detail I really liked in the source material was the E shape on the pelvic surface.
Ah, yes, the E shape. If you look at the front of the sacrum, the smooth side facing your internal organs, the attachment of the piriformis muscle creates this perfect capital E.
It traces right around the holes.
Yes, the pelvic sacral foramen where the vital nerves come out.
And on the backside, the dorsal surface.
It's very rough. It's convex. You can clearly see the remnants of the old separate bones. You have 5 vertical crests running down it.
Like a fossil record.
Very much so. The median crest right down the middle is where the old spinous processes fuse together. The intermediate crests are the fused articular processes, and the lateral crests are where the transverse processes fused.
Now, running right down through the middle of this fused bone is the sacral canal. But the text noted that at the very bottom, there's an open door, the sacral hiatus.
Yes, the sacral hiatus. It's shaped like an inverted U or a V. It happens naturally because the lamina of the 5th sacral vertebra usually fails to fuse in the midline. It leaves a permanent gap.
Why does that bony gap matter to us?
Because it's a direct access point to the nervous system. The actual spinal cord itself ends much higher up in the lumbar region, but the cauda equina,
The horse's tail.
right, the horse's tail of nerve roots, runs all the way down through this canal. And doctors can actually use this hiatus to inject anesthetics for a caudal epidural block. It's basically the service entrance for the lower nervous system.
And hanging off the very bottom of that service entrance is the coccyx.
The tailbone.
Just 4 tiny rudimentary vertebrae.
Right. It has these little horns called the coccygeal cornua that reach up to meet the sacrum. It's vestigial, meaning we obviously don't have a tail to wag anymore, but it's not completely useless.
It still does something.
Oh, absolutely. It still anchors very important pelvic floor muscles. You'd miss it if it were gone.
Okay, so we've built the pillar, we've locked in the protective ribs, we've stacked the heavy lumbar blocks, and we've fused the sacral anchor. Now we have to drop this whole assembly into the basin, the bony pelvis.
This is where the anatomy gets really, really interesting, because it stops being just about structural support and suddenly becomes about human survival and reproduction.
First, let's orient ourselves, because the text was extremely strict about the proper anatomical position of the pelvis.
Yeah.
It is not at all how I pictured it in my head.
Most people picture the pelvis like a soup bowl sitting perfectly flat on a table.
Right, that's what I thought.
But in the living human body, it is tipped way, way forward.
How far forward are we talking?
Well, the strict anatomical rule is this. The anterior superior iliac spine, that's the prominent bony point on the front of your hip that you can feel sticking out.
ASIS, for short.
Right. The asis and the pubic symphysis, which is the joint right in the front center, must be in the exact same vertical coronal plane.
So if I'm standing flat against a wall, both of those points touch the wall at the exact same time.
Exactly. And the tip of the coscix in the back is perfectly level with the upper border of that pubic symphysis in the front. That means the bowl of the pelvis is actually facing much more forward than upward.
It's designed to catch the heavy abdominal organs like a tilted shelf, not hold them like a flat cup.
That is a great way to put it.
Now, the pelvis itself is divided into two distinct parts, the greater and lesser pelvis.
Yes, divided by the pelvic brim or pelvic inlet. The greater pelvis is the upper flared out part. It's called the false pelvis because it really just supports your lower intestines.
But the lesser pelvis,
That is the true pelvis. That is the tight, rigid, bony ring below the brim.
the actual canal for childbirth.
Correct. And this is exactly where we see the most dramatic structural differences between human skeletons. We actually classify pelvic types based largely on the shape of this specific inlet.
The text listed 4 main types. Let's focus on the 2 most common ones, gynecoid and android.
Okay, so gynecoid is what we consider the typical normal female pelvis. It accounts for about 41.4% of women.
And what's the shape?
It's round or slightly oval. It is very spacious. And importantly, the subpubic angle, the arch, right under the pubic bone, is wide. It's greater than 90 degrees.
And the android type?
That is the typical male shape. It makes up about 32.5% of male pelvis. The inlet is heart-shaped rather than round. The cavity itself is funnel-shaped, and that subpubic arch is very narrow.
Funnel shape sounds absolutely terrible if you were trying to push a baby through it.
It is terrible. The text explicitly notes that if a woman happens to have an android-shaped pelvis, which certainly happens, childbirth is significantly more difficult. The outlet is physically reduced, so the fetal head gets stuck in the funnel.
There were 2 others mentioned briefly. Anthropoid, which is oval front to back, kind of ape-like, and platypeloid, which is flat and oval side to side.
Right, but the gynecoid and android represent the 2 main functional extremes.
This brings up the evolutionary context you mentioned earlier, the obstetric dilemma.
It is the ultimate tug-of-war in our DNA. To walk efficiently on 2 legs, we really need narrow hips so our legs stay directly under our center of gravity.
Makes sense for running.
But to have big-brained, intelligent human babies, we need very wide hips to get the head safely out. The female pelvis is the evolutionary compromise between those 2 conflicting needs.
The source highlighted some very specific sex differences beyond just the inlet shape to accommodate this, like the sacrum itself.
Right. The female sacrum is naturally shorter and wider. By being shorter, it doesn't curve as far forward, so it interferes much less with the birth canal.
Creating a wider cavity.
Exactly. The male sacrum is longer and more distinctly curved, so it actually intrudes right into the pelvic space.
And the sciatic notch?
That's the large curve on the back lower part of the hip bone. In females, it is wide, almost 90 degrees. In males, it is a tight, narrow 70 degrees. Literally every millimeter of bone in the female true pelvis is shaved back or widened to create room.
Which brings us to arguably the most technical part of the source material, pelvimetry.
The clinical science of measuring that room.
This is where geometry directly meets medicine. Doctors need to mathematically know if the bony door is actually big enough for the passenger.
Exactly.
The text talks a lot about conjugates. These are essentially diameters, right?
Yes. Internal measurements of the pelvic ring, and the absolute most important one is the obstetric conjugate.
The true bottleneck.
Right. Imagine looking down through a bony ring. The obstetric conjugate is the straight line distance from the sacral promontory, that's the jutting lip on the top of the sacrum, to the inner bulging part of the pubic symphysis in the front.
It's the tightest possible squeeze for the baby's head.
It is. It is the shortest distance.
Yeah.
And it is usually slightly less than 11 centimeters.
11 centimeters? That is really not a lot of room.
It's barely enough. It's basically a pass-fail line for natural birth. If the fetal head is physically bigger than that invisible 11-centimeter line, the baby simply does not come out.
But here is the real kicker from the text. It says, you can't actually measure this specific line in a living, conscious patient.
You can't. You cannot reach the inner wall of the pubis with a manual exam. It is physically impossible. So doctors have to use a clever workaround called the diagonal conjugate.
Which is just more geometry.
Essentially, yes. During a vaginal exam, they measure from the sacral promontory in the back to the lower bottom edge of the pubis in the front, which they can actually reach.
Okay.
And then they just subtract about 1.5 centimeters from that measurement to estimate where that tight inner spot is. They are literally doing mental math on a triangle to determine if a natural birth is safe.
That is wild to me. We are using invisible triangles to predict the future.
That is clinical anatomy for you. It is a game of millimeters, whether it's the exact overlap of the thoracic spines preventing you from snapping your back, or the exact width of the sciatic notch allowing a new life to enter the world.
Structure dictates function.
Always. Structure dictates function.
And sometimes, unfortunately, structure dictates pain.
Very true.
So to wrap this up, we have traced the entire pillar today. We've seen the heart-shaped chest bones that protect our lungs, the massive kidney-shaped lumbar bones that carry our weight, the precarious L5 junction that's always trying to slide off the sacrum, and the incredible gender-specialized basin of the pelvis.
It really highlights that the spine isn't just one single thing. It is a brilliant series of specialized tools seamlessly fused together.
It really is. Now, before we sign off, I want to leave you with one final thought from the source material. It's something called the Triangle of Marseille.
Ah, yes. The anatomical deep cut.
It sounds like the title of a spy novel. It's this tiny triangular space deep in the pelvis. It's defined by the side of the L5 vertebra, the edge of the big psoas muscle, and the wing of the sacrum.
It is a very crowded neighborhood in there.
Exactly. And running right straight through that tiny geometric space is the obturator nerve.
This is such a perfect example of why this millimeter-level anatomy matters. Think about what's in that space. You have a heavy weight-bearing bone, L5, a massive muscle, the psoas that changes shapes every time you walk or run, and a highly delicate nerve, all fighting for space in a triangle roughly the size of a coin.
So if L5 slips forward even a little, or if that muscle spasms,
The triangle suddenly closes, the obturator nerve gets crushed, and you feel shooting pain down your inner thigh. It's a stark reminder that we are packed incredibly tight inside. Everything relies on everything else staying exactly in its proper lane.
anatomy really is destiny, my friends, or at least it's the specific architectural blueprint we're all stuck with.
So treat your central pillar nicely. It's doing an awful lot of heavy lifting for you.
Absolutely. Thanks for joining us on this deep dive. We'll catch you on the next one.
Stay curious.